few people logged in. Well, thank you all for joining us. This is CIVHC's monthly Change Agent Chat. My name's Jay Want, and I'm CIVHC's Chief Medical Officer. Before we get started, there's just a few housekeeping things that we'd like to take care of. Your phone lines are muted, and we'll be using the chat feature that you should be able to see in the lower left-hand corner of your screen to field questions that allow you to make comments on the discussion. This is only round 2 of doing this, but what has worked well the first time was about 20 minutes of discussion with the guest, and then we'll go to your questions after that. The webinar is being recorded, so it will be posted on the CIVHC website in case you have people who want to view this after the time without any cost. So next slide. So the definition of insanity is doing the same thing and expecting a different result. So in the case of American healthcare, that means if we don't change anything, we get to keep spending twice as much as our industrialized competitors around the world and getting worse results. But I'm convinced that we can do better and that the different and better ways are unlikely to come from some central plan. Probably not the Affordable Care Act completely, probably not the Republican bill that's going through Congress right now. But that the biggest changes are probably going to be innovations that come out of the local level. I'm convinced more and more that that's likely to be the case. And indeed, when we looked at Colorado, we found a lot of places that actually are doing exactly that. With limited resources, these change agents are starting to deliver on the promise of the triple aim: lower cost, better population health, and better patient experience. And we're excited to bring these people to our stage so that we might all get a little bit smarter together. I'm thrilled, actually, today. I'm doing this from Seattle, but I'm thrilled to have our friend Christy Whitney, who's president and CEO of HopeWest in Grand Junction, Colorado, as today's guest. Christy is a master prepared registered nurse who began her hospice career as a nurse almost 30 years ago. Actually, over 30 years ago. She helped found an all-volunteer hospice program in Durango in 1979. Later served as Vice President of Mercy Medical Center in Durango and CEO of Hospice in Northern Virginia. She was recruited to Grand Junction, back to Junction, I guess, in 1993 to be the founding CEO of HopeWest. Beginning with just 6 employees in 1993, HopeWest now serves thousands of patients and grieving family members in Rio Blanco, Mesa, Montrose, Ouray, and Delta counties. A state-of-the-art facility in Grand Junction and 5 satellite offices act as bases of operation for 300 employees and more than 1,500 volunteers covering over 7,000 square miles. Every staff member and volunteer is committed to providing patient-centered care to patients and those supporting them, working to ensure that whatever time a person has left is comfortable and as meaningful as possible. HopeWest is dedicated to profoundly changing the way the community experiences serious illness and grief. And this is the important part, one family at a time. So, Christy, thanks so much for joining us today. It's a real pleasure to have you here.
Thanks, Jay. It's really always fun to talk about this stuff.
Yeah, and Christy and I have known each other for a little while because of some of the work I've done in Grand Junction, and it's the more contact I have out there, the more impressed I am with HopeWest and how it's really so well integrated into the community. And so I recall having a conversation with you once in which we were talking about the kind of the anomaly, the low Medicare cost in Grand Junction that's been publicized by Atul Gawande and so many other people. And your comment was, well, I wonder how much that has to do actually with HopeWest, with the fact that we have such an active palliative care and hospice program in Grand Junction. Do you have any data that actually kind of supports that notion?
Well, I've done a lot of studying and researching on this, and there's an indisputable fact that even if you look at before HopeWest was created, we still had low Medicare costs here. So I think that's the credit of, frankly, the work of the IPA. So I don't want to steal their credit. But the fact that we've sustained that over time, I think, does have a lot to do with our organization, not just hospice care. And when I talked to the folks at the Dartmouth Atlas, they said they did do some looking to see whether there was a correlation, and they couldn't really find a correlation. And there was a recent study done that looked at Medicare data, and in that sample size, which was relatively small, I will say, and only looking at the diagnosis of cancer, they did see that longer periods of hospice care in high-cost areas seemed to drive down costs. But I think we have the lowest Medicare costs in general, but we also have really low Medicare costs the last 2 years of life, which I think is different than a lot of areas. And I think that has to do with the broad range of services of palliative care. And also the grief counseling services that research does show lowers morbidity and mortality of survivors of patients who die.
So you just made a distinction, basically, that maybe some of the differences in the longer period preceding death rather than just the immediate period surrounding. Is that right?
I think it's both. I think that certainly every patient, we also have a very low hospitalization rate at the time of death. We have a low mortality rate in our hospitals, and it's just driving lower every day. I mean, since the advent of our inpatient care center that cares for almost 700 people a year, those are probably 350 of those people would have died in the hospital. And so I think that those costs keep getting lower because, depending on when someone transfers over and how much of their DRG they used up, but theoretically they're getting lower. And some people never go to the hospital. They just come to the care center to die. And otherwise they would be admitted to the hospital with much more expensive services.
So one of the things that we always deal with is, I'm happy basically to tout Mesa County and Grand Junction around the country when I speak about it. I always cite Grand Junction as a community that works. But some, comments that I get back is, well, that's Grand Junction. I mean, that's nothing like, and you can fill in the blank here, Cincinnati, Ohio, or Albuquerque, New Mexico, or whatever. People kind of, think that maybe there's something special in the water in Grand Junction that allows you to do all this stuff. Right. What do you think about that? I mean, and so that so people may kind of roll this into the Grand Junction phenomenon. Well, of course they have hospice, and of course it's effective because it's Grand Junction. So it's been wildly successful in Mesa County, but in lots of other places that isn't the experience of hospice, unfortunately. In that the standard way that people die of terminal illness is in the ICU with lots of lines and lots of drips and lots of monitors going off all the time. Do you think the difference actually is the Western Slope, or is it the work of HopeWest, or how much is each one of those things?
Yeah.
Okay,
well, a lot
go
of
ahead.
people say the same thing to me, and then I point to McAllen, Texas, that has 40 for-profit hospices in the same population and the highest Medicare costs in the country. And to me, those two extremes are interesting. We have one
44?
Yeah, something like 44. I mean, it's a lot.
Oh, my
God. It's shocking
okay.
number. I mean, I say 44. Maybe it's only 25. But, I mean, it's over 20. and no nonprofit hospice. And so I think that's all an interesting situation. I think that having lived in a metropolitan area and worked in hospice and utilized some of the same principles and saw them work the same, I don't really buy it. I think the Grand Junction certainly has a collaborative history, and the IPA, again, our doctors, the climate of our physicians, I think, is unique, and I think that has driven some of our success for sure. But I do believe that this model could be duplicated pretty much anywhere, and I think when people don't, it maybe is a little more complex other places. Instead of having 3 hospitals, I might have 15 or, whatever it might be. Everything is more complex and has to be scaled up. You couldn't do the exact same model with the exact same infrastructure and expect it to work in Cincinnati, Ohio. But I am convinced if we took the core methodology of how we operate to Cincinnati, Ohio, we would have the same results.
So help me out with that. Let's say I operate a hospice in, Billings, Montana. What am I doing wrong, or what am I doing differently than you're doing? I mean, you just said basically that it should be replicable in my environment, and yet that's not been my experience. I still have people, kind of calling in the last 48 hours, not really kind of doing advanced directives or basically kind of getting the whole program. What should I be doing differently?
Well, they had hospice 15 years before HopeWest existed, and it was pretty much the same. The average census was 25. Now our average census is 450. And not that many more people moved to Grand Junction. So I think it's an absence of vision, and I think it's an identity crisis, frankly, of the institutions. So, and depending on my structure, I may be a sub-department of a hospital. So I'm, 5 departments down from the CEO. I'm just kind of fill a tack on, and I think you used the term the other day when we were talking that it really resonated with me, is the difference between being a strategic social change agent or being a responsive service provider. So if you see yourself as a responsive service provider, you wait till the phone rings and you respond. And that's it. You actually said that. I thought it was brilliant. Maybe I've edited it, but I think that is the difference. I think that we see our work as social change agents. So everything we do is geared toward how do we engage the community? How do we bring about transformation of our community's experience? That's different than being a responsive service provider.
Yeah, and that's I found that just fascinating. That you don't really see this as a service per se. You see this as a social movement. Can you unpack that a little bit for me? I mean, what exactly does that mean? I mean, I think of hospice as, oh, well, there are these billable codes, and I enroll people and I disenroll people. But you're talking about a much broader scope than that, just in terms of the way you interact with your community. Can you say a few words about that?
I think that really comes from, maybe my own personal history of getting into hospice when it was an all-volunteer social reform movement in 1979. There was no Medicare. It was all volunteer. People sat in living rooms all over the country and tried to figure out how people could die differently in this country and have a different experience. And so, I kind of got into hospice, if you will, from that vantage point. So I never have really seen it any different than that. And but certainly at the same time, the complexity of the business of hospice, gratefully I was smart enough to figure out too. I mean, because it was lovely, running an all-volunteer hospice, but, Medicare money's nice, and so now we have a budget of $40 million, and I have to have the business acumen to run that kind of a business, but at the same time, not lose focus on the why of the business, which is social reform.
So talk to me a little bit about that balance, because you really do view this as a business with market share, with basically a strategy in order to be able to infuse your market. Some people might think that is being somewhat different than what they conceive of as hospice, as this kind of benevolent kind of social force. But you don't see it that way. You see them actually as integrated, don't you?
I do. I see them completely integrated, and yet I feel like in a growing fashion, maybe that's the dinosaur part, because I feel like people kind of gravitate to one side of that coin or the other, regardless of profit status.
Right.
Either they fancy themselves, the best business company and the smartest minds and the most ruthless, business models, and they brag on the fact of what their profit margin is, or how they're keeping their staffing under control, or whatever their identity is around. And there's another camp of people who perhaps are to the other extreme of, I don't have to really run that tight of a business if I can raise a little money, and maybe I don't need to be that shrewd at contracting if I can raise a little money. And we kind of see it as both, that the only way we can really achieve the growing vision that our organization has is to be absolutely impeccable on the business side and impeccable on the social side.
So let me just push that one loop further. So is there anything wrong with there being a for-profit hospice versus a nonprofit hospice?
Historically, I would say no. I think it's all in how you do the business, depending on, and so I have really close, long time friends who started the for-profit hospice business. I would say a lot of what I learned about the business side of hospice, I learned from them, so I can't really throw them under the bus. And I've referred a lot of patients to them over the years. But, they went from being privately held to being owned by Roto-Rooter and traded on Wall Street. And the people I know, there's one person I still know who works there in the senior leadership team. But, the perils, the benefits and perils of Wall Street financing, are more on the peril side than the benefit side, and that's hard to see. It allows you to scale, and in some ways, perhaps the hospice movement would not have ever taken off if VITAS hadn't scaled with venture capital money from Wall Street. However, the burden has been the street kind of owns what you do, and you're in the short-term gain of what are you doing for me this quarter versus what's your vision for the next 20 years.
Yeah. So let's talk for a minute about that long-term vision, and tell me, give me some concrete examples about how you are a social movement, or how you're actually embedded or engaged into the community, how essentially you raise consciousness about about how the quality of the care and the quality of life matters so much at the end of life?
Well, yeah, I have a friend, a longtime friend, who was a hospice pioneer, who used to say, death is not a medical event. So let's start there. If death is a social event, then everything you do has to be about how do we close the last chapter of our life. And so we know we're complex people, we're complex families, and if the patient and the family are the unit of care, that means we're watching the kids who are 8 years old. What's happening to those kids in that family? How are they reacting to what's going on? How are they going to be afterwards? How is the spouse coping with identity changes? How's the spouse coping with all the stress of being a caregiver? All those things matter. And then really leveraging the collaboration, the community, is really means not duplicating resources. And I think that if we get in the competitive mode of duplicating resources, there's less to go around. And so part of it is the healthcare integration that we do that creates the outcome, but as well as the social integration to where the people are who need to know about what we do. And so if you think about having 1,400, 1,500 volunteers, they're all attached to a family. All those people know what we do. If we do a lot of fundraising, we have events that have 1,500 attendees, or all those people start to know about hospice. If we have a commercial restaurant that the community eats at, all those people start to know about hospice. And it destigmatizes something that is the scariest thing in our lives, that most people will just as soon not say the word. And so we've done a lot of specific things to destigmatize what we do.
That's just fascinating. So, to make the segue, there is kind of, there's a natural fear. I remember when I was running IPAs, this was one of the most difficult topics for physicians to deal with, ironically. It was one of the ones that they had the hardest time basically with kind of wrapping their brain around and what their purpose was. And then, in a prior presidential campaign, the term death panels came up. And in fact, in my view, that was a terrible pall that was cast over the ACA because of that term. One, do you ever hear that? And two, if you have, how have you actually dealt with that kind of, this is just another form of a death panel?
Okay, so don't you like my favorite cartoons here on death panels? But I only hear death panels like looking in the rearview mirror. When I'm in Washington, I hear about them. When I'm in Washington, but I hear them more as a passe, stupid phenomena. I've never really ever heard it locally. And I think, and it's funny because the health plan, I think probably had to think real seriously about how far in front were they going to get on their support of hospice and HopeWest. Because how does that make them look, right? They're funding the creation and the support, and they're giving the money to a hospice. That can't be good. But I think when you look at how we see who our clients are, that we have clients for the last chapter of their lives, which means years. And so I think if we were really a brink of death hospice, I think it'd be a little harder to gain community input and support. If people felt like only people who were involved with us were people in the last week of life, I think that would be very hard. And so I think it's been incremental over 25 years that we've changed the community's, we've changed what the community thinks hospice is to not being a brink of death operation. But in changing our name to HopeWest, people just think we help people who are sick. They don't really think of us as just a hospice.
That's interesting. So basically, you've kind of you've redefined your niche. It sounds like that you're not simply those last few moments, but you're about the quality of people's lives through the last years of their lives, not simply just kind of a terminal event. Is that right?
That would be correct. Yeah.
Incredibly cool.
The average length of time, I think, in our palliative care program, for example, I just had that statistic, was 458 days. So that's a little bit over a year before then the person would be transferred to hospice for every number of months. So really we're trying to, and as we expand our mission into PACE, and the average time a person's in a PACE program is about 2 years. So we're really in that last couple of years of life as our targeted population.
That's amazing. A reminder to those listening in that now would be the time, if you have questions, please enter them in the chat box. And I'm not seeing any, Steph. Is that right now?
That's correct. We don't have any yet.
Okay, very good. So I'm gonna follow up with one more question, and it actually has to do with my own personal experience with hospice. My father-in-law actually died of prostate cancer about 4 or 5 years ago in northern Kentucky. It was just an eye-opening experience for me because I'm an internist, my wife is an internist, and despite that, we had absolutely no ability basically to manage his care from Colorado. It was a nightmare because there were conflicting orders. I recall there was they received a call basically from his urologist saying it was time for him to come in to have his stent changed. And we called them up and said, do you understand he's in hospice? And they said, well, we just do this, kind of on a regular basis. We could not, in fact, kind of, oftentimes keep the medical industrial complex off of him, unfortunately. And I distinctly remember the only time his care actually made sense to me was after hospice came in. After he actually entered into hospice, everything started to make sense again. I guess my question is, why do you think that is? Or first of all, do you see that commonly? And second of all, why do you think that is? Why do you think so often our traditional medical pathway doesn't make sense to people until you guys show up?
Well, I think that if I just use one reason, I guess I would say because we tend to deliver care only by means of how it is paid for. And so increasingly, and unfortunately increasingly, it's all provider focused. It's not so patient focused. So and highly specialized and fragmented just by design because and now that we have hospitalists, it's even the gap between the primary care physician who used to see the patient in hospital rounds every morning and talk in the hallway with the surgeon or the oncologist. Now it's a hospitalist, but it's not the hospitalist is there 5 days a week. There's a different hospitalist there every day. And so it's fragmented even among the providers. and so I think part of it is a lack of communication, conflicting orders, all of those things. And then because we're in a paradigm when you're in the acute care system that we're very scientific about everything. So if you have a change in a symptom, we got to know why. So therefore, we're going to do a scan, and we're going to do this, we're going to do that, we're going to do blood tests, and we sort of forget to ask the question if we're going to do anything with the information that we get. And that's kind of not part of the equation. I don't think it's quite as capitalistic as a lot of people might say. I think it's more just a paradigm of treatment. So if you're a physician or a hospitalist and you see a person who presents with XYZ symptomatology, and you don't know right off the bat what it is, you're going to order tests. That's the routine, and that's what people get caught up in. And then, and again, like all business models, I have a friend whose dad is 93 and getting dialysis, and who I tried to have a conversation with, like about whether she was sure this is the course they wanted to take, and of course there's a whole paradigm that they enroll the patient and the family in, which is, as you say, it's you just do what you do when you do it. It doesn't really matter that the person is closer to death or the burden of coming in for dialysis or father's going in for dialysis by ambulance. I mean, none of that is ringing a bell with anybody because, again, they can bill it. And they know their business model, if they're, privately held or traded on Wall Street, has to do with, how many people got X amount of treatment and how much average dollar, per day. And so they're not really in the mode of, and then if you challenge them, they would say, well, it's the patient's choice.
Yeah.
Right? Yeah.
That's oftentimes what they do. But just so I'm clear on what you're saying, you're not saying that it's bad intent, but the way their business models work enables that kind of behavior, right? I mean, if you get paid to do stuff, you tend to do stuff.
Yeah, I mean, it's not like you're really thinking about every day, I think I'm going to get more money if I keep this 93-year-old on dialysis. It's just that the systems of care are such that, and the care deliverers are, oftentimes the physician's not sitting there plugging a person into dialysis. It's a technician. And a technician wouldn't consider it their job to question, right?
So the train just gets rolling and it just keeps rolling in the same direction.
That's my theory, anyway.
Yeah. So I'm going to give you the magic wand question, which is, if you could change one thing about the existing medical system, how would you change it basically to make it more resemble hospice, more resemble palliative care? What would you do?
I've thought about that a lot because I really think that PACE without walls, I think PACE is a really good model, and it makes a lot more sense than the hospice Medicare benefit by far. I think that, again, for this population of the last several years of life, I wouldn't extend that model beyond. But I'm also, and this is going to sound a little harsh, and this is where my notion about for-profit versus nonprofit. Now that we have the advent of for-profit PACE and a capitated model, I don't believe they go together. You know, I think it's is it Howard Miller, who's the economist, that says the capitation relies on altruism, and I think so if you have a capitated insurance product in a for-profit model, i.e., you know, the ones we have, and then you're extending it now into PACE, you know, trust me, MedPAC is going to hate themselves later because they're going to try to figure out why are they gaming the system and making all this money off of PACE. I mean, it's really not that hard of a concept, but apparently it is for policymakers. And so I do subscribe to that theory that nonprofit capitated health care is one model that could work. I don't think we're headed there as a country, but I think it could work.
So again, just so I'm clear on what you said, you worry about the profit motive overlaid in a capitated system because there's a built incentive to withhold care within that system?
Yes.
Yeah. Okay. I just wanted to make sure that I was, but you think capitation could work in a nonprofit model, basically. You know, if it is a community-owned, community-centered, it potentially is functional in that way.
The other thing is why I'm a believer in the best possible way. You get that community engagement and financial support rather than a model where, and I think they're talking about this week on Capitol Hill, but rather when everyone else gets rich and then we're going to ask the community to take the burden. You know, and I don't think that's fair. Whereas if you're funding in a capitated environment, a nonprofit model, they can raise money, they can turn to the community to get money, but nobody's getting, you know, a yacht, you know, in the equation, right? Right.
So in your vision, basically, hospice is actually an integrated portion of the community. It's not something that meets the community. It is something that is actually woven into the fabric of the community. Is that a correct interpretation?
Exactly.
Okay. Mm-hmm. Well, we've got about 2 minutes left here, so we're getting close time to wrap up, but I have to say, just from my personal experience of you and your organization and your role in Grand Junction, that's exactly what you are there. In fact, I have lunch with or breakfast with Steve Erkenbrack in your cafe fairly frequently. At Spoons when I go there. And so anyway, as I said before, I'm a great admirer of your work. It's really been a pleasure to talk to you about all this, and you have our thanks really for joining us. In closing, I want to let the audience know that the next Change Agent Chat is actually on April 28th with Greg Smith from Colorado Para to talk about his initiative basically to bundle certain major joint replacements for his organization. We'll also keep your eye on your emails. We actually are probably going to have a discussion on April 14th as well, kind of a supplemental one to talk about the current goings-on in Washington with the AHCA and the ACA and the replacement. Lord knows where we'll be 3 weeks from now when we have this discussion, but I can promise that it will probably, not be settled, and it probably will still be a pretty interesting thing. And with that, I think we're at the bottom of the hour, and I want to thank everybody for participating. Unfortunately, we got a question, but it came in too late, unfortunately, for us to address that. Thanks a lot. Again, this will be posted on the Civic website, and once again, we're really happy to have had Christy and HopeWest on today. Thanks a lot.
Thank you, Jay.
All right. Talk to you later. Bye-bye.